Hi everyone, I hope you can hear me. We're going to get started very shortly. If you just give me a thumbs up in the chat just to let me know that you can see my slides and you can hear me talking. Okay, nice. That's good. Okay, brilliant. I think we've just gone past 8 o'clock, so let's crack on. There's a good few of you here. We're almost hit 50, which is pretty good at this time. I'm just going to do a quick intro and then I'm going to hand over to Vishnu, who I can see is tuned in, which is excellent. But for those of you who don't know me, my name is Shoaib and I'm the course organizer for BitePACES. We've been doing our courses for over 2 years now, and we've had several hundreds of doctors go through our courses with, I think, somewhat a decent amount of success. People seem to like the courses, and we have two variations, a 1 day and a 3 day, coming up in May, June, July time. So please do check those out on our website. I'll post links in the chat. But if you want a quick QR link, it's there at the top right. And I think we used to do a 4 day course, but we've condensed this down into 3 days now. But I think we can pretty much fit everything we do in the 4 day into the 3 day. So hopefully that's going to be exciting. And I know not everyone can afford to come on the courses, so we have our WhatsApp group that's got kind of a good few hundred of you on there. And many of you sitting cases this diet, and we have free webinar series. You don't have to pay a thing, and you can come along to those. All information about the webinars are on the WhatsApp group. And yeah, I'm on the WhatsApp group as well. So if you ever have any questions, you can just chat me. I know some of you have messaged me and I will reply. Just it's been super busy today. I'll try and get back to your messages this evening. Yeah, £20 discount code if you use the code below. We have sold out for our 3 day course in May, just as an FYI. So if you do want to get on the course, please buy your tickets ASAP, as this cohort seems to be very popular. Tickets are selling fast. Got some good reviews. You can check those out on Google. I'm not going to go on too much about those, but yeah, these are our next few webinars. So Vishnu here today is an endocrine reg. He's run a clinical consultation series for us for several months now, very popular, and he'll walk you through some crucial cases. We have something put aside dedicated for IMGs on Saturday, and then we'll have an overview of the common cases. A lot of you are messaging me asking me what comes up in various hospitals and things. I'm reluctant to disseminate that information, but I think if you come to this webinar, or if you have a good overview or grasp of the common things that will come up, you should be absolutely fine. So please do join us at that webinar, join the WhatsApp group, check out our courses, and without further ado, Vishnu, I'm going to hand over to you.
Thank you. Thank you, Shoaib. Let me just get to my slides ready.
Yeah, sure.
Shoaib, may I let me add me back on, or I can't share?
You have permission. You should have permission. Let me make you a co-host. Hold on. Okay, you should be good.
Perfect. Thank you so much. Hopefully that is now sharing. Shoaib, is that all?
Yeah, that's all good. You're on full screen now, so that's good to go.
Perfect. All right. Just as Shoaib was already introduced, I'm one of the endocrine registrars in London. And I've been doing this clinical consultation, and I've been trying to think about new ways of presenting the session. So today, the overview of the session is just to make sure that everyone who's attending this webinar is aware of what a clinical consultation entails, and what is expected of a candidate, to try and develop an approach for any sort of clinical consultation or scenario that's thrown at you to enable the highest scores. And I'm going to cover some common presentations and scenarios that come up. Now, we'll talk about that in a bit more detail when I go through my slides. I've done this in every single webinar, and every single webinar I've done, I've just made sure that the carousel is made clear. Okay, so this is what you would go through during PACES. And what we're talking about today in this webinar is station 2 and station 5, which is a 20-minute station in total. Okay, so it's a big chunk of your entire PACES experience, as it were. So when you use your old book, so there are some new books and resources out there, but just remember when you go and look on the internet and Google whatever it is that you look for, everything before used to be geared for an old style of consultation, um, which was 10 minutes each, and you had sort of two complex patients and you had to do the whole thing. Now, what they've done is they've expanded it, so it's a 15-minute station just for the history examination, sort of setting the expectations with the patient and making sure there's some questions. And ICE stands for ideas, concerns, and expectations. And there's a 5-minute separate time allocated for a discussion between you and the examiner. Okay, so it's a much more bigger station, much more relaxed and less condensed, and therefore it means that the station itself is the clinical scenarios that present in the clinical consultation now are slightly different because of that, because you can cover more things. So there's less of the spot diagnosis. I must, acromegaly, for example, being an endocrine reg, that would be something that would come all the time to clinical consultation. That does not mean it does not come. It just means that it's less of that and more of you have time now to take a history and examine a patient and, clarify things as you go along. Now, here I've done what I would suggest as my sort of prompts whilst you examine do the consultation. So 4 minutes brief history. Now it has to be very focused. Remember, you get to plan the station. Then you have 7 to 8 minutes to examine and clarify history. So again, remember, you can ask questions while you examine. You just have to be good at it. So you be able to practice it in person and make sure that you are understanding what the patient is telling you whilst you're examining. Okay, so some people can't do two things at once, and that's fine. But if you can, it's a real time-saving method. Then I would suggest that you leave some time, sort of around the 11-minute mark, so you've got 4 minutes left, to make sure you ask patients if they've got any questions, if they've got any concerns, and what you're going to do for the patient. So if the patient is in ambulatory care, so ambulatory care, I'm sure most of you know what that is, or some places call it STEC. What is that going to happen to the patient? Are they going to be admitted into hospital? What investigations will they have and what those investigations will look like? And what, if you're not going to admit them to hospital, what the follow-up plan is? So I think it's really important to go through all of those things. And remember, if there's anything in the clinical consultation that is important, i.e. Epilepsy, drive-in, for example, advice has to be given. And then there's a 5-minute viva. I'm just going to put this in practice. So I've done this previously, this exact same scenario, and I think it's quite a good scenario to use to base how I would approach it and how I would prepare. So on the left is one of the MRCP scenarios that they have that's readily available on their website. This is how the format is, by the way. So they give you this to prepare before the station. So Mr. Cruz is a 66-year-old man. You're the core medical trainee in the MAU unit. So you know exactly where you are in the hospital. So that's the first thing to always remember. Where are you in the hospital? Are you in MAU? Are you in ED? And are you in resus? When you read the scenario, you need to remember where you are and think about, at the end, after you've done the history and the exam, where the patient should be. Okay, is the current location of the patient appropriate? And if not, where would you move the patient and how you would move that patient? Next thing is to read the prompt. So in this case, this patient, just to give you the summary, has come in with a blackout, but it's fully recovered. Okay, they've got some routine blood tests, which they've told you is normal, and they've also got some observations. Now you need to sit there and think of what your differential diagnosis list is. So blackout, I would broadly say there's cardiology and neurology involved in that. Okay, and then I will think about what systems I would need to examine. So if the history suggests that this patient's had palpitations, I'd go for more of a full cardio exam. And if it's suggestive of more neurology, then you wonder if it's epilepsy or seizures, and then you have to go down a more, a focused neurological exam. Now, remember, you do not have to examine the entire system. You can take bits and pieces of the system. So if it's neurology, you don't have to do a full neurological exam top to toe. That is not something you can achieve, I don't think, in the time frame. What you would choose is the big, the things that really matter. So power. So for if it was for blackout, I would get the patient to walk. So that's my easy screening test. I'll quickly check the facial nerve and sensation, do tone, power, and reflexes in the upper limb and lower limb, and I would do a focused cardiovascular exam, and that will be pulse, peripherally, just check, and then move on to the precordium to look for any murmurs that may have caused or predisposed to a syncopal episode or blackout. So those are the things that I would do in that. And then in my 4 minutes, I would ask the patient, depending on where my history and exam has led me, I would explain that the patient would have to stay in hospital, for example, for further tests. These are what we think it could be caused by. And then remember to just always cover the safety points. So in this case, it's blackout and drive-in. Other safety points that are common that turn up in PACES is if you're going to prescribe something that is to a woman who of childbearing age, just think about whether she is pregnant or could become pregnant and think counsel on contraception. And if there are side effects, well identified side effects of the drugs that you're going to prescribe, you have to counsel and screen for any complications, i.e. if someone needs a aminoglycoside for a urinary tract infection or pyelonephritis, just quickly ask about their hearing in their history. Please do ask questions as we go through, but I hope that's quite clear. So just to go further in, this is what I would have done. I've sort of told you what already. So this is what they sort of get on the other side, and I think it's sometimes quite useful to sort of see what the actor or the patient, So there's, if it's a patient, and in your exam it will be a patient, they will have an agreed sort of script or agreed sort of thing that they will cover, and obviously these patients are so experienced, they've done this all the time, so just remember that they probably have come to the exam for 10, 15 years, so that they're very well experienced, so they know their story and they will just repeat it at will. What they are advised, though, is to, hold some bits of information back. Some of them will do that unless you ask specific questions. You can have the slides, and this is recorded, so I won't spend too much time because I really want to focus on getting you guys to practice. I think there's a couple of volunteers that have, but that's what the history is. This is, again, all of this will be, they either have it in their heads or it's written down as their script. You don't see this, obviously. So this, so you can see that this patient's got paroxysmal AF, and there's a family history of cardiac problems. So that's leading you down a more cardiac route. These are the sort of questions that they're sort of agreed to ask to you as the candidate. Okay, so you will have to answer all of these questions as you can. So that's why that 4 minutes is quite useful. Now, if in the exam you just cannot remember what the guidelines are, you can always do what you do in real practice, which is to check with the guidelines and come back to them. Okay, so don't remember that this clinical consultation is an artificial thing to try and see what you would do as a medical reg. Now, if as a medical reg you just sort of say that the safest thing is that you would check and come back, that's fine. Okay, ideally you would know whether they can drive and not, and that's something that I would urge you to all go and look at in terms of the guidelines. But if you do not know, then always offering that is still a reasonable answer. Survivor, so usually every single Viva is very different, depending on the case, but usually there's some idea of you summarizing the key issues of the case, asking for a differential and management plan. If the differential wasn't clear when you did your history, then and they will always come back to that sort of safety question if it's not been addressed clearly in your history or your consultation, as it were. And that's what the mark scheme is. Okay, so the mark scheme here. So remember, all domains are tested in these stations. Okay, so that's why it's such an important station. It carries a lot of marks. As you can see, this is how the mark scheme is portrayed. Okay, so they have a differential diagnosis and they have plausible alternate diagnosis. If you do not get the probable diagnosis as one of your in your differential list, you will not get full marks in this station. Okay. If in terms of clinical judgment, if it's a sensible plan in terms of appropriateness, that's fine. Managing patient concerns and managing patient welfare, they are self-explanatory, but you can see where the 4 minutes or the 3 minutes of whatever time you spend at the end is really important to really make sure that the patient feels as if you've really addressed their concerns. Okay, before we start on to practice station 1, I realize I've sort of given you a whistle-stop tour of how I would approach a station in terms of preparation and how how the patient sees it and how the examiner sees it. And we're going to put that into real practice, just because I don't think it sort of really makes sense unless you see it in action. I wonder if I've got a couple that volunteered on the chat on the WhatsApp group. I'm just making sure that they're here. If you can make yourself known again, just making sure that I remember their names. Sorry if I have forgotten. Mina, okay, yes, I do recognize. And perfect. And Priya, okay. So Mina, because you put your hand first, let me just unmute you and I'll explain how this works.
Hi there, Vishnu. Thank you.
Okay, so what I'm going to do is, because obviously you can't examine a patient virtually, so there's no point you having the whole 15 minutes. I will give you a total of 8 minutes.
Okay.
My suggestion is that you use 4 or 5 minutes to take a history. I will give you sort of some feedback in terms of what an examination would look like for the patient, if you were going to do that in real life. And then I'll give you some time to go back to the patient and explain what your management plan would be.
Okay.
And then we'll do a viva at the end.
Okay.
Does that sound good?
Yes, thank you.
Perfect. So total of 8 minutes. And I'm going to give you, because it'd be boring for everyone to just watch you prepare, you have sort of a minute maximum to just have a look at this scenario. Okay.
Yeah.
Everyone else on the webinar, do what you would do. So just make notes on how you would approach this sort of history. Okay. And think about what your differential list would look like. Yeah, Mina, your time for preparation is up.
Okay.
So please start.
Sure. Hi, Laura. My name is Dr. Mina, and this is the emergency department. Can I just check that you're 65 years of age?
Yeah, I'm 65 years old.
Right, Laura. I hope you're feeling better. Did you come with someone today?
I did. I mean, my husband's just left. But yeah, I've come because I've collapsed.
Yes, I'm so sorry to hear that. Can you tell me exactly when this happened?
Just this morning, I just collapsed at home.
Can you tell me what you... Yeah, oh, sorry. Carry on.
Well, I just got out from my sofa up to make a cup of tea, and I just collapsed in the living room.
I see. Did you manage to make the cup of tea?
No, I didn't even get to the kitchen. I collapsed in the living room, I said.
Okay, okay, okay. And has this ever happened in the past?
It has, and it's happened quite quite a lot actually, quite worryingly in the last sort of 2, 3 months.
I see. And what have you sort of thought it might be? Any ideas at all?
I have no idea. I mean, I'm normally really quite fit and well, so I don't have, I've got I had high blood pressure in the past,
Mm-hmm.
but I'm not on any, I didn't need any tablets for ages, and same with diabetes. I was diet controlled.
Mm-hmm.
Apart from that, I'm normally really fit and well, so I have no idea. I mean, I feel like I'm drinking. I obviously would know that drinking water can be a problem, and I've been drinking a lot more water,
Mm-hmm.
so I don't really know.
All right, all right. And Laura, if you don't mind me asking, if you can remember at all, prior to these multiple episodes of collapse that you have had in the last couple of months, have there been any sort of symptoms that tell you that a collapse might be happening in the next few minutes? Has that happened before?
So this morning was completely like I had no warning, nothing.
Mm-hmm.
And actually, to be honest with you, most of them I don't. Um,
So you've not had any sort of racing of your heart or
no-
dizziness?
so yeah, people have asked me this before,
Mm-hmm.
because I went to my GP the second time it happened, and this was
Mm-hmm.
2 months ago,
Mm-hmm.
and actually they said drink more water as well.
Mm-hmm.
Um, in terms of, I do feel dizzy,
Mm-hmm.
and but I feel dizzy all the time.
Okay.
Um, and did you say my heart racing? I have noticed it a few times, but not all the time.
Okay, so you've had a bit of racing of your heart, and then you're saying that you're quite dizzy most times.
Yeah.
How about any chest pain or any difficulty breathing? Has that happened before?
No chest pain, no difficulty breathing.
Mm-hmm.
I think you should know that the dizziness. So you asked me if there was any symptoms before I fell.
Mm-hmm.
What happened a couple of times, I did feel a bit dizzy
Mm-hmm.
before I fell, or before I lost, before I sort of blacked out, I think.
Okay. Now, you mentioned that you were getting up to make a cup of tea. So you were standing up from a seated position. And is this something that has been replicated in the previous times that you have collapsed? Is it always from a seated position to standing, take a few steps and collapse? Is that
I guess
what's
it
been?
I guess it's soon after I stand up.
Mm-hmm.
But yeah, I mean, there was one where I sort of just sat up in bed, and I just sort of I don't know what happened, but yeah.
Mm-hmm.
But usually it is either when I get out of bed or stand up.
Okay, okay. And the other thing I'd like to ask you is you've been well in yourself in the last 2 weeks. You've not had any fever or problems with your bowel or bladder.
No, I've not.
Not as in you've been well, yeah?
Yeah, sorry, I've not had any fevers
You've
or.
not had any fever. Okay. Can I just check quickly, Laura? You mentioned about high blood pressure and diabetes, which is now diet controlled. You're not on any other regular medications otherwise?
No, so what I was saying is that diabetes, I now have started tablets.
Oh, well, sorry. Okay.
I was diet controlled for 3 or 4 years, but
Mm-hmm.
just recently, the last year, my
Okay.
blood pressure's been a problem, and my diabetes is now a problem.
Okay. And so you're also on blood pressure tablets then?
Yeah, and also metformin and is it dapagliflozin?
Okay. So how new is the dapagliflozin for you?
Um, Probably 4 months
Four
or five
months.
months. So
Four,
last year.
five, 4, 5 months. Okay. And metformin as well.
Yeah, then that was the start of last year.
Started last year. Okay. And the blood pressure medication, are they new? I'm just looking
Blood
for
pressure,
recent
I've been
medical
on just been on
changes.
amlodipine for 5 milligrams for years now.
Okay.
Although I've noticed my blood pressure is a bit more sort of erratic. So
Okay.
it sort of goes up and down. I don't really know what to do with it.
I see. I see. Okay. And can you tell me if you've been experiencing any problems with breathlessness whilst you're asleep at night, for example? Do you suddenly awake, feel
No,
quite breathless?
no
No.
problems with breathlessness. No.
No.
The only other thing is there's a bit of sort of grumbling in my tummy.
Mm-hmm.
Um, it's not pain, it's just sort of discomfort. So sort of
Mm-hmm.
left side.
Mm-hmm.
Um, yeah, sort of, I don't know, just on the side really. It's something I've just noticed recently, but I don't know what to make of it.
Okay. And is it to do with your food? Intake of food?
No, nothing to do with my food. No, nothing.
Okay, does anything make it worse?
No, I guess when people press on it, I do feel a bit dizzy or lightheaded, but otherwise, no.
Okay. And is there anything that makes it go away?
No, no, as in it just goes away by itself. I'm not been taking painkillers for it.
Okay. Well, what would you describe the pain as? Sharp, dull?
It's more dull, it's sort of grumbling. You've had 6 minutes now.
Okay. All right. And has there been any sort of collapse episodes in the family as far as you know?
No one else has. I've asked. The GP asked that same question. No, no one else has it.
No, and there's not been any family member with any problems with blood vessels, such as, like aneurysms where the vessels swell up at a point,
I don't
that
think
sort of
so.
thing.
No.
No. Okay. No surgeries, Laura?
I've not had any surgeries. No.
Okay, and no allergies as well.
No, I'm not. I know.
That's fine. Thank you for that. Can I quickly just check with you that do you consume alcohol?
No, I don't drink anymore. No,
That's great. How about smoking?
I've never smoked.
And I don't think you've done any illicit drugs.
No, certainly not.
No, that's fine. That's fine. Thank you for that, Laura. Would it be all right if I examined you?
Yeah, sure.
Can I just check, Laura, exactly where on the left side of your abdomen is it painful usually?
So it's in the So I'm going to describe it to you. It's in the left upper quadrant.
Okay,
Sort of. Yeah.
that's fine.
Just in the left upper quadrant.
Okay, thank you. I'm just going to start by looking at your hands. I'm going to take a set of observations. So your blood pressure and your pulse. We've got the readings here.
The pulse is regular.
Regular pulse. There's no fine. Any JVP elevation?
No, JP's is sunk into the supraclavicular fossa. So it's
Okay. And no pallor,
no pallor,
jaundice.
no jaundice.
That's fine. Hydration status, fine.
Dry tongue, but otherwise fine.
Dry tongue. Okay. I'm just going to have a feel for any glands, any swelling, swollen glands. So looking for lymphadenopathy.
No lymphadenopathy, no swelling glands in the neck.
Okay.
Stop.
Okay. And I'd like to examine your chest, Laura. So I'm just going to have to expose the chest.
The chest is unremarkable. Heart sounds are normal.
Okay. And then no murmurs.
No murmurs. Heart sounds are normal. Yeah.
And chest is clear otherwise.
Chest is clear.
Okay. Having a look at the feet, looking for pedal edema.
No, there's no peripheral edema at all.
Okay. All right. Right, Laura, thank you for letting me examine you, but I'd also have to have a look at the tummy if that's okay.
Okay.
Are you in any pain now?
No, I'm not in any pain.
Okay, I'll be careful. If you're in any pain, please let me know. So just superficial.
So there's no scars. The abdomen's soft, and as you palpate, there's no tenderness.
Okay, deep
Bowel sounds are
palpation.
present. Sorry.
Okay. Okay. Bowel sounds present.
Yeah.
No masses, organomegaly.
So you can feel a mass or a lump in the left upper quadrant, so lower down, so left flank area.
Okay. Okay.
But it's not painful to touch.
Okay. It's not painful to touch. So left flank. All right. Kidney is not palatable otherwise, and fine. Right, Laura. Just a few quick questions. I mentioned about your bowel and bladder habits just before this. You've not been having any diarrhea or any blood in your stools.
No,
That's
not had
fine.
any of them.
Okay. Looking at your blood pressure, it seems like it's sitting a little bit higher than usual, but it could also be because you would be quite anxious coming to the hospital now. Your heart rate is otherwise okay, and you've got a regular pulse, so that's really good. The blood tests have come back okay, but I think there will be a bit of a workup that we're going to have to do, and this is going to include a hospital admission. Would that be okay with you?
I mean, sure. I mean, what do you think it is?
So it could be a few things. It could be it could be to do with your blood pressure and your hydration status, of course. But I'm also a little bit concerned about the new medications you've been started on for diabetes. So I think we need to make sure that you're not actually going into dips in your blood sugar, which we call hypoglycemia, something you might have been you might have heard before, and to do with your abdomen, and you were complaining about the pains that you've been having, or rather the discomfort you've been having. I'm just a little bit concerned about a little bit of a bulge that I was able to feel whilst feeling your tummy, and this is going to need some scans.
Okay, what type of scan?
So I'm thinking of a CT scan in the first instance.
So I had a jelly scan,
Okay.
and they said they found something like near my kidney,
Okay. All right.
like a
Oh,
lump or something. So I don't know if you felt that.
okay. Well, I did feel a sort of a lump bump, but I can't tell for sure exactly how close it is to the kidney, or if it's something higher up. You seem to be having the discomfort higher up in the left side of your tummy. So there'll probably be a few things to rule out here, and we'd still need to go with the CT scan, if that's okay.
Yeah, that's fine if it
Yeah.
helps.
There will be some specific blood tests as well for us to take. So this will all be in keeping with advice from the endocrine team as well, because I'm considering some hormone-related conditions here, suggesting, I mean, just looking at your blood pressure being quite erratic, as you mentioned. Do you have any other concerns?
How long will I be in hospital for?
So I think it really depends on how much, how you improve, number one, and of course, the results of the investigations. So considering all of the above, I think it's fair to say that because you've been collapsing, there's something that's interfering with likely your blood pressure, and it's most likely a hormone related thing. I hope that's quite clear for you.
Where's the hormone coming from?
So if you've had a jelly scan and a sort of a mass has been found adjacent to your kidneys, then it could be from a little gland that sits just above the kidney. It could be that, but I'm also considering something to do with the pancreas, and the fact that you've also been on medication for for your blood sugar, diabetes. It could be that
Okay, I'm going to
you're having.
move you on to the Viva
Okay,
section, as it were.
okay, okay.
Okay, so what's your differential diagnosis?
So differentials in this patient, I still like to rule out cardiac syncope in the first instance, and then I'm considering a pheochromocytoma and an insulinoma.
What cardiac causes of cardiac syncope are you willing to rule out, or wanting to rule out even?
Cardiac syncope from an arrhythmia or heart block.
Okay. Why
Yeah.
do you think insulinoma is a differential here?
Insulinoma may be a differential because the patient was recently started on some oral hypoglycemic agents, and she's having sudden dips in her. I mean, she's having dizziness associated with syncopal episodes, so it's something to rule out, I think.
Wouldn't the dizziness be related to medications, not because of the why would she have developed a insulin producing tumor?
Yeah, it's only a differential way down the list. I probably have to have a rethink, or investigate
What are
appropriately.
you planning to CT?
CT scan of the abdomen.
Okay, so just the abdomen, not anything targeted.
Abdomen pelvis. That's um in the first instance. I just because I've felt a mass.
Any specialist tests that you would send? Because you mentioned those to the patient.
Yes, so I'd like to check baseline investigations, obviously full blood count, looking out for infections, anemia, renal and liver function, as well as a CRP, a coagulation screen
Why?
as part of the workup.
Why would you send a coagulation screen?
Yeah, actually, she's not in for any procedure just now. No, I'll cancel the coagulation screen. I can't
Yeah.
explain it.
What's your special test? Sorry, remind me.
The special tests will include urine, so urine dip and urine for glucose. And metanephrines as well.
Perfect. Okay, end of station. First of all, thank you so much for volunteering. It helps a lot for the process, I guess.
Thank you.
So that's really helpful. So it's obviously really difficult when you do it in front of almost say 80 people on the webinar at the moment. So let's just go through this case. I made this, well, I don't want to give it away, but basically presentations are similar in a way, just for my own sort of enjoyment as well, because as much as it's fantastic teaching, but it's also quite fun going through these cases because they can be quite vague, can't they?
Yes.
So syncope is one of those things that it's quite a broad topic. And I think you asked a really detailed history. I think you eventually identified there was a postural element to this lady's syncope or collapse. I don't know if you were clear in your mind whether you were separating neurology syncope with cardiac. So that's just one thing to be wary of. So just make sure that you just ask about, were you incontinent? Was there any tongue biting, any history of epilepsy? Just be very bold with that.
Okay.
Even though this is very suggestive of a cardiac syncope, as it were. I think you did ask about sort of other family members with syncope, but she's 65, so so what are the cardiac causes of syncope? So this is how I remember it. I remember it with a mnemonic called AVOP. Okay. A stands for arrhythmia, V stands for vasovagal. By the way, you can take it, this is one of those sort of made up ones I made up myself. O stands for outflow obstruction, which is HOCM or aortic stenosis, and P is postural hypotension. So she classifies in the last one. Technically, everything is a cardiac syncope in a way, right? Because or like everything that can cause a vasovagal theoretically, right? Which is cardiac syncope, unless it's a seizure. So yeah, A, arrhythmia, V, vasovagal, O is for outflow obstruction, which is aortic stenosis and HOCM, and P is postural hypotension. So she's got labile blood pressure, and I'm not sure if you nailed her down on that. She did volunteer that was low, and that invites hypodynamic circulation states which are pathological. So that can bring in your endocrine conditions. Obviously, there's a bit of a clue because I'm an endocrine reg. It may have been an endocrine condition. So I think just in terms of your examination, I think you probably it would have been easier if you did it in person, but just really think about what you're going to examine, because you can't examine all of that and also take the history you took in the amount of time that you have.
Yeah, that's true.
Yeah, so you had 12 minutes, sorry, 12, 13 minutes just of history and me telling you what the exam is. So you didn't actually physically do it. Okay. I'm just curious if anyone in the chat. So what would you, if I had to pin you down, what would your diagnosis be? People in the chat, people in the webinar, you can also post what your thoughts were in terms of what you think about the diagnosis. And if you've got any questions so far.
Yeah, can I just add, Vishnu, just from the STEM, I wrote down 3 things. So cardiac syncope, hypertensive urgency, and postural hypotension. But as the history moved on, then with the symptoms and things, I was thinking along, insulin producing tumor versus FEO. I'm not sure how off tangent that actually is.
How
off tangent, like thinking of an FEO chromocytoma.
Well, I'm going to tell you what the answer is in a second.
Okay.
But I was just curious. I just wanted more people to commit to their answers.
Sure.
So theoretically, at the moment, there is still a wide differential list, even after the history you've taken. Okay. Now, what she does have is a postural hypotension and labile blood pressure. She also has palpitations, so that was part of the history, and rapidly progressing diabetes. Okay. So her diabetes, she was diet controlled. Now she's on 2 tablets. Okay. If you asked her, I actually held this back, but if you asked patient, she could have told you what her HbA1c was. too. Okay, so you can always ask like really specific questions.
Okay.
Now, labile blood pressure like that could be, and most likely is in terms of the endocrine conditions is feared. Okay, that does not mean things like Addison's. I can see people have written out Addison's, and cons are less likely. And carcinoid, so carcinoid is much more rarer, and you're more likely to get flushes and other sort of symptomology depending on where it is. So this case was meant to be a pheochromocytoma. Okay, so that was the answer. So actually, well done. You got there. I threw in the lump because actually, so I've presented this case based on a merge of what a real patient has presented with in my unit, as well as what a PACES case had for
I see.
this sort of. So I've merged them together, but I've taken a few details just so it's a bit clearer that it was a fear rather than anything else. Now, the reason why insulinoma is unlikely is, number one, it is super rare.
Yeah.
Number two, the questions you would need to ask for that is, do you feel better? So there's something called Whipple's triad, which is,
Yes.
do you feel low after a meal, or do you feel low before a meal? Does food improve it? Now, unfortunately, Whipple's triad is hampered by the fact that most people would feel better after eating something sugary. Okay, that is the fact of life. That's why if anyone has a shock, a cup of tea with sugar helps. Okay, but you would have to ask a few more questions. So and the other thing is her diabetes had worsened, which would not be in keeping with insulinoma, right? It shouldn't
Yes,
really worsen.
that's
So
true.
that's
Yeah.
probably why it makes that less likely.
Yeah, of course.
Addison's. So the reason why Addison's is less likely is because you're in a state of volume depletion, and your blood pressure would be quite low. In Theo, what you actually have is you have a situation where your blood pressure changes as you go up because of the catecholamine excess, your blood vessels are really narrow. And when you stand up, you don't have you actually start losing the volume to keep you upright. So you drop your blood pressure. So you have a hyperdynamic circulation, and also it's dependent on catecholamine excess or secretion, which is not constant level. It's up and down. Okay, I hope that makes sense to people.
Yes.
That's why it's a hyperdynamic thing. Cushing's is unlikely because collapse is quite a rare phenomenon of Cushing's. One mechanism of that would be hypokalemia. Same with cons. Arrhythmia. Now, what would be interesting about the arrhythmia is it's still a differential. I don't think you can ever say from the history and exam and the information you've been provided so far that you can rule it out. So you obviously need an ECG, and if any further, a Holter. Now, what makes it less likely is that there are some symptomology of lightheadedness, and it's very related to the fact that it's positional. Okay, so arrhythmia is you should be collapsing, you should be losing consciousness or output at random times. The other thing is the palpitations wasn't a major feature of her symptomology. Okay. Please explain about lump. Can we feel so? Not usually. Okay. It's just because this is what this patient presented. Her tumor, adrenal tumor, was 20 centimeters or something ridiculous. Okay, so it was huge. So it was grumbling. So yeah, that's so normally you wouldn't. What is interesting though is that some people will explain that if you press on in the area where it could be, you do actually get a surge of catecholamine excess because you're just pressing on the organ that has all of it. So theoretically that could have happened.
Would Vishnu, if you don't mind me asking, would that actually be something not to do in an exam?
You wouldn't know. So I mean,
Okay.
if someone tells you there's a lump, you're gonna have to feel it.
Okay.
Or you have to look for it. I'm just going to answer a few questions if that's okay. I'm sorry if I've missed any, because I think a lot of them were differentials. So I'm just going to the first one. If your top differential is wrong, but mention fear on the differentials and investigate for this, you would not lose marks. So to be clear, Harry, you would not lose marks. So especially in something as broad as this, I think have a wide differential list. Just be very clear about it, but also to understand why you're justifying it. So I feel insulinoma would be something that's a bit out, doesn't quite fit. Should we check for diabetic neuropathy and diabetic exam? I think if you're starting to check for diabetic neuropathy in this station, must be really good for time. Okay. So I don't think so. I wouldn't necessarily suggest that as a 100% that you need to. Now, if for example this woman was tripping over, then you're going to check for sensation and proprioception at the peripheries. Okay, so you're going to have to tailor your exam to the presentation. Is autonomic dysregulation worthy of a differential? Yes, I guess so. I wouldn't. I would put it in the differential list. But I wouldn't say it is something that I would want high up on the list. And Ahmed's asked, how does the pheo lead to worsened diabetic control? Or is this not? So it is related. So it is a feature of catecholamine excess where you have it's purely just because of the catecholamine is just either co-secretion of cortisol, which is quite common or not uncommon, I should say, or because that you have catecholamines which worsen your diabetes, and because of the increased mobilization of glucose. Okay, so yes, it is related and it is a feature or phenomena. So rapidly progressing diabetes, it's not a common differential, but it's something to think about in a sort of middle-aged, old, woman who's not doesn't phenotypically look like someone who should have type 2 diabetes. Think about catecholamine excess or an adrenal paraganglioma, etc. Any other questions? And I hope you sort of understand the management. I think your management was very appropriate because you said keep in hospital, good. ECG, maybe Holter, depending on the ECG. Refer to endocrine, and you had your specialist test input. Any questions from yourself, Mina, or any questions from anyone in the webinar before we move
That
on?
was really, really very helpful. Thank you.
There is someone. Oh, hold on. Sorry, I've missed. How would cortisol excess lead to syncope? I've said it. I've said cortisol excess would not. Sorry, if that wasn't clear. So Cushing's or glucocorticoid exposure should not lead to syncope unless. Oh, sorry, I know what I said. So unless it is dropped your potassium because of the mineralocorticoid activity and led to an arrhythmia. It is a very long answer, so I don't think that'd be a top differential for syncope. Okay. If the patient looks phenotypically as in when you examine them, as if they've got glucocorticoid exposure, like they've got cushingoid face, interscapular fat pad, then you can say that's a feature, and that's your answer to why that could do it. But no, typically I would not expect someone with Cushing's to collapse, really. Any other questions at all? Sorry, I missed that. That was on the Q&A thing. Okay, I think that's enough of those questions. I think could you simulate an answer to the Viva, please? So before that, what is the mnemonic helpful in syncope? Sorry, I'll do this quickly. So I remember it as AVOP. I'll just type it in at the end. So that stands for arrhythmia, vasovagal outflow obstruction. So that's aortic stenosis or HOCM, and postural hypotension. All right. I'm going to move on to just for the interest of time mainly. I will simulate a Viva, how I would answer my own Viva, as it were, or I would write it in the text. But I just want to make sure that that we get a second station if that's okay. And I'm going to look for my next participant. I think it was Faria. I'm not sure if you're able to talk and you're still with us.
Yes, can you hear me?
Yeah, we can hear you, I think. Okay, similar situation as Mina. So I'm going to give you a station, and you have a minute to read through that and prepare, and then we'll go through the station together.
Okay.
Your time is up.
Okay. Hello, good evening. My name is Dr. Vaseem. I'm one of the doctors in the emergency. Is it okay if I confirm your name and age, please?
Yeah, I'm Isman Shah, and I'm 24 years old.
Okay, so what brought you here today?
Well, I lost consciousness whilst I was actually driving, and I crashed into a tree, and yeah, so that's why I'm here, I guess.
Um, really sorry to know. And is it the first time it has happened?
Yeah, I mean, I've never crashed before, but and I've not lost consciousness before, no.
Okay. And before I move on to further consultation, just to confirm, do you have any previous medical conditions?
No, I've got nothing. I'm
Okay.
yeah,
And I presume you are not on any regular medications.
no.
Okay. So you lost consciousness, and when was that? Was it today in the morning?
Well, in the afternoon, I literally I went out to, I was driving,
Yes.
and then I started coughing, and the next thing I know was
Okay.
I was being,
Okay.
there's an ambulance and stuff, or
Yeah. That's really unfortunate to know. Was there somebody with you while you were driving?
no, no, that was it. I was all by myself. The only good
Okay.
thing I think, because I was on the phone, like I
Okay.
didn't have a phone in my hand. Don't think I was on the phone on the touchscreen thing, and yeah, and I started coughing and I crashed. And I don't know if that meant someone got help quickly, because I
Okay.
was just in a sort of residential street.
All right. And before the loss of consciousness and the crash, did you get a warning feeling that you're about to lose consciousness?
Not really. I mean, I guess I was too busy coughing.
Mm. So you
Yeah,
got a coughing fit
yeah,
before this.
yeah.
Okay. And did you had any chest pain prior to this?
I guess so. Yeah, there's always chest pain when I cough. Um,
Okay.
my heart was racing.
Your heart was racing. Okay. And um, were you sick in previous days? Anything like fever, cough, or any viral illness, anything like that?
I didn't have a fever. I have had a cough for a week or so.
Okay.
Sorry, I
And
can't remember your last question.
were you bringing up any phlegm with the cough?
Yeah, yeah, I was bringing up sort of green stuff.
Okay. And where when you had this coughing, like was it quite severe when you were driving?
It was, yeah, it was. I mean, all I remember was like a real like coughing fit. I mean, I stopped like another one. But yeah, I've been getting
Okay.
these sort of coughs, and this is definitely the worst one. I sort of kept on coughing.
Okay. And any shortness of breath?
Um, Not really.
Okay.
I mean,
And
I've
yeah.
been a bit more breathless when I'm, exert myself, to be honest. Yeah, I guess so. But not when
Okay.
not when I was driving. I was, just sitting
Okay.
down.
Okay. And normally, in your routine, you are fit and active. Do you exercise?
Yeah, I do. Yeah, I go to the gym
Okay.
and I play football things.
So, ever when you have been exerting, like doing gym or playing football, have you felt palpitations or your heart racing very fast?
Um, I don't think so. Nothing out of the
Okay.
usual.
Or have you ever felt that when you are exerting, you feel dizzy or that you lose consciousness, anything like that?
I've, I've never lost consciousness and I've not felt dizzy. What I will say is I have become a bit more breathless, a bit more easily, and I don't know. I just put it down to this. I mean, recently I've had this cough, right? But before then I don't know. I just put it down to not. I didn't exercise much in the winter, so I just thought I was lost a bit of fitness.
Okay. So, as you said, there was nobody with you, but you were on the phone, and the next thing you remember was the ambulance. So, when you came around, did you notice that you had bite your tongue,
No,
or did you had sorry to ask, but did you had any incontinence, like you lose any urine or any bowels, anything like that?
No to both, no.
Okay. And coming to the breathlessness, is that a recent change? Like, is it been getting worse slowly?
I guess so, yes, especially with the coughing, whilst I've been coughing.
Okay. Okay. And normally, how many pillows do you take to sleep?
One.
Okay. And you don't wake up in the middle of night feeling breathless?
No, I don't.
Okay. Okay. So just to ask further more questions, how has been your appetite lately?
Been okay. Not really
And
changed.
no changes in your weight?
I've lost a bit of weight.
Okay. Was it intentional?
Not really. I didn't. I mean, I didn't want. I know. I didn't tend to lose weight. No.
Okay. Um, and would you know how much have you lost?
Sort of 5 kilos, maybe.
Okay. Over what period of time?
Probably a couple of months.
Okay. Okay. And any lumps and bumps in the body you noticed?
Um, I've got to swelling in my neck, but apart from that, nothing else.
Okay. And is it been increasing in size? Where exactly in the neck? Is it front or the side?
It's at the front. And I don't. I don't know. I mean, I don't think it's increased in size. It's just been there. I've just sort of accepted it. I've had that for. I mean, I noticed it maybe even a couple of years ago.
Okay. Okay. Um, have you noticed any shakiness of your hands?
Not really, no.
Okay. Um, how is your sleep?
It's okay. Yeah, no, nothing changed.
Okay. Any issue with bowels? Any constipation or loose bowels?
No, not really.
Okay. Any issue with your waterworks?
No,
Okay. Any joint pains
no joint
or
pain.
swelling?
No,
Okay. Or any rashes on the body?
none.
Okay. Do you smoke?
I used to, but now I vape.
Okay. So how long have you quit smoking and switched to vaping?
Probably started smoking when I was 18. Switched to vaping a year ago.
Okay. And do you consume alcohol?
I do, yeah.
And how much over the week?
Um, just maybe, I don't know, just sort of. It's not consistent, right? So just maybe a couple of glasses or cans
Okay.
of beer. But yeah,
Okay. Have you ever noticed that when you consume alcohol, you feel more sweaty or sweaty or hot?
not really. No.
Okay. And you don't take any other drugs or anything?
No, I don't take any other medications.
Okay. Okay. And do you have any family history of any medical issues that run in the family?
None that I know of. No.
Okay. Is it okay if I examine you now?
Yeah, sure. What do you
Okay.
aim to examine?
So first I want to have a journal look at you and then to look at your hands to feel your pulse.
Yeah. So he's got a regular
Like,
pulse. Um, it's fast. It's 120 beats per minute.
okay. And
Seems
then
regular.
I look at the hands or any sweatiness or anything, any tremors.
Yeah. So as you can see, I've put it up
Yeah,
there. So he's got a fine
yeah.
tremor. It's sweaty and clammy. You do notice
Mm,
there's a lump in his neck, and it looks like goiter. And then you
okay.
quite
So
rightly go and check his thyroid.
examine his thyroid. Ask him to swallow his spit and then go at the back and try to palpate it.
Yeah, so he's got no retrosternal extension, and his swallow's fine, and he has brisk
Okay.
reflexes. Anything else you want to
Okay.
examine?
Um, mm, just for the cardiovascular system for any murmurs.
Yeah, but he's got no murmurs. Um, so on his cardiovascular examination, he's got no murmurs, but he's got a palpable P2.
Okay. 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 Can I quickly ask you if you have been having any trouble in swallowing your food?
It's got no, I don't.
Okay. And you mentioned about the breathing difficulty. So is
Yeah,
there any change in your voice you have noticed?
no change in my voice.
Okay. Okay. And yeah, so um, what do you think is going on? Like, what are you worried about?
Well, I mean, I sort of collapsed at the wheel. I don't,
Yes,
it doesn't, my car's completely totaled.
yes. So,
I'm sort of worried that's going to happen again, and I don't know if I can drive. I don't know if I can, what if it
yes.
happens? What if it happens? Yeah, I
Yeah,
don't know
you
what
had
happens
a
again.
pretty serious situation. So, in the first instance, I would advise that we will admit you today, to do further tests and investigations. Would that be okay with you?
Yeah, sure. I mean, what are you looking for?
Yeah, so what I think is that one of the glands in the neck, which we call as thyroid gland, it is quite swollen. So it seems like it is producing hormone more than it should, and which has caused you, which might have caused you to go into irregular heart rate, or and that would be the cause of your loss of consciousness and might have caused you this accident. So we will need to do some basic blood test and some specific blood test for the thyroid hormone, as well as we'll do the ECG, and we will also do the ultrasound scan of your neck to look at your gland. Um, so it will need further testing, and you will be admitted with us for at least a couple of days before we can think that you are, we have a diagnosis, and then we can guide you further.
For the interest of time, because it's almost 9, I'm going to move on to the Viva section. That was 11 minutes. Sorry for you.
Okay.
I sort of asked some questions. So what is your top differential?
So my top differential would be like thyrotoxicosis, and it's thyrotoxic storm basically,
Okay. How
or
do you?
which could have led into go into arrhythmia, which would have led into loss of consciousness.
Okay. And what would your next steps be?
So at the first instance, I do have his baseline observation. Like I would like to do like complete set of observation, including any postural drop. I would like to do an ECG. I would like to put him on telemetry. I would send some blood tests, which would include basic blood tests like full blood count, Usenis, thyroid function test, and also depending if the thyroid function, which we are expecting that T3 and T4 would be raised, we can do the antibody testing as well and arrange for an ultrasound scan of the thyroid. And I definitely will refer him to an endocrine team as well. Um, and we'll put him on telemetry at least for 24 hours.
Okay. I'm going to stop the Viva early as well. Just sorry, but I just called the time, and I hope you're okay that we can go through the case.
Yes.
Whilst we just talk briefly about how you did. People, if does anyone want to put some questions in and their own differentials into the chat, the webinar chat here. Again, as you can tell, I had a theme today, which I thought would be quite interesting just to do it as a themed sort of clinical consultation, and sort of other sort of and actually focus on endocrine, as it were. These are actual real, or both real cases. The first one I did adapt from a real sort of a PACES case that has been used in the past, um, whereas this is a case I've seen with a few changes, obviously. So yes, so there's two possibilities here. Thyroid storm or thyrotoxicosis is the underlying main diagnosis. The mechanism why this person has collapsed could be an arrhythmia, or could be because of decompensated heart failure or sort of pulmonary pressures. That's what I was going for with the couple of P2. The most likely thing is actually arrhythmia. I just was curious whether you would have picked that up. Vagal tone from coughing would have been perfectly acceptable, or anything with a lung parenchymal disease where coughing causes a drop in the pulmonary pressures, and also into into what he eventually had, which was a collapse, or because of his primed, or as it were, deteriorated heart function because of the fact that he's had thyrotoxicosis for perhaps quite a while. Anyone know how you can tell if someone's had thyrotoxicosis for a long time and for a short time? I'll come on to yeah, so such cough syncope is an interesting one, which is possible, but you know, not with the I don't think with the other sort of features, I would go completely with that. P, yeah. So one of the things you could do with that pulmonary hypertension would be a a CTPA, because if depending on an echo. So if you looked at that ECG, but again, you can't make a decision. Give me 2 seconds. Just making sure that my laptop didn't die as we're doing this webinar. Can you explain how he has pulmonary hypertension? So this is not related to his thyrotoxicosis at all. He has pulmonary hypertension for a separate reason, which is still actually unknown, but there's a whole differential list for that, which is, as Harry actually said straight up, includes some of that. So either interstitial lung disease, so I'll get drug use. So there's certain drugs that could be it, but it's not helped by the fact that he's also got the second pathology. And yeah, Irfan's got a few more. Now, I just wanted to catch up with a couple of thoughts. So MEN2, I'm not sure where you're going with that. I wouldn't have thought MEN2 here. It's not something that would feature here, okay? Because MEN2 is a syndrome, and patients normally have a pheo, pituitary tumor sometimes, and also more likely to have medullary thyroid cancer, and if it's meant to be marfanoid features. So this patient doesn't have a medullary thyroid unless you're trying to say that this patient's got a calcium disorder which has caused the arrhythmia, okay? Because medullary thyroid cancer are not usually thyrotoxic. Drug-induced, so mostly eye signs. So I asked a question about how could you tell? I actually did give you one clue, but I don't expect you to know this. That's part of why we do this. So the ALP is an isolated high. ALT is normal, Billy is normal. So ALP suggests that there's bone turnover, and that's what happens in thyrotoxicosis. There's loads of other causes of bone turnover, I accept, but in this specific case, that's why I put it there. That's not something I expect you to know. That's just something I expect. I just want you to think about. You know, there's and remember that every single time a piece of information is given, there's a reason for it. Eye signs would only be in Graves. That it's true. Remember, this patient didn't have eye signs really, but that does not mean they don't have Graves. It just means they don't have eye signs, for some reason. I didn't tell you about thyroid acropathy, but this patient also didn't have that, so it's a bit odd, I accept. But yeah, eye signs pretypical mixed edema and thyroid acropathy, i.e. clubbing, will be different. Can you tell how can this be purely thyroid, as he doesn't have any retrosternal extensions / symptoms? You don't need retrosternal extension for Graves or all thyroid issues. He does have symptoms because he does occasionally get palpitations, and he does have the tremor. We'd have to ask him some sort of specific questions about. He also has weight loss, by the way, which is another symptom of 5 kilos, which is unintentional. Some other questions I would ask specifically for thyroid excess would be heat intolerance as well. You did ask about bowel habits and other things. Were the infectious symptoms just a red herring? I actually think I almost forgot about the infectious symptoms.
Yes.
Sorry, Priya, do you want to ask a question?
No, I'm okay, thank you.
Were the infectious symptoms just a red herring? No, these were real. I actually think it's contributed to the reason why he had a cough syncope, pulmonary hypertension, and then collapsed, or sorry, lost consciousness, as it were. So I don't think it's a red herring. I think it's just the final bit of decompensation that's happened on the background of thyroid excess. But the key case is thyroid excess. interesting that this was the thing that pushed him over the edge, as it were, and in terms of his cardiac function. So it's a high output cardiac state, and he's finally got something that he just can't compensate for. So I think it is all related in a way. Any other questions? I appreciate that was a sort of, difficult case and sort of out there case. The first
Can
case
I
is
ask something?
go on.
Sorry. Is it the thyrotoxicosis which is causing the heart failure and raised P2, or and then causing the cough? I don't get this bit actually.
So no, it's not. So the thyrotoxicosis is what he has, which is causing heart failure. So he's got a high output cardiac failure, but he also has now developed a cough and a chest infection recently. And he's got a background of pulmonary hypertension, either because of years of smoking. So these two things have decompensated him and caused him to collapse. So the heart failure is because of the thyrotoxicosis. So you may have had years of it, or a couple of quite a few months of it, which has weakened his heart. Okay, so he's more prone to an arrhythmia or loss of output. Okay, so does that make sense? So that's the first bit. And then what's happened is he's recently developed a chest infection, which is worse, and that cough sort of fit in, and that's worsened because he's got pulmonary hypertension from perhaps years of smoking, and that's caused, with the thyrotoxicosis, that collapse episode. So they are sort of things that have come together to cause his issues. Okay, but what started this all off is the thyrotoxicosis. So people with thyrotoxicosis, high output state, heart failure states, they should not usually, no, what am I trying to say? There's usually a decompensation episode or reason for them to finally lose output, is what I'm trying to say. So they don't just, carry on, and then suddenly one day just happens. It's possible, but usually sometimes there's a trigger for them to finally decompensate and present to hospital if it's a thyroid storm or etc. Any other questions on that case? Any questions on clinical consultations in general? The first case, or just in general, how to prepare, or how one approaches the station. I'm just making sure that I've not missed anything in the Q&A. Sorry.
So overall, what's your feedback for this? Was it okay?
For your feedback, yeah. So I think there's a really good detailed history. I think there's a few elements that you missed for thyroid. In terms of your management, that was exemplary. You put the patient in, got them the right investigations, and also the right on the right path. So yes, so you would have easily passed. That was a very difficult case, and I almost just threw it in there just so people think a bit more lateral and just realize that it's not going to be as one diagnosis. There can be multiple things going on. So there's a sometimes you do have these cases where there's a tiny bit of, oh, you must link this with this. Okay, that's not a typical level case. That is what I would say a higher, what's the word, more difficult case for PACES, but those sorts of cases have turned up and will continue to turn up in PACES. I'm just going to answer two questions. Did the heart failure cause syncope, or could it all be? I've left this open, so it could all be arrhythmia, or it could be the fact that they had decompensated pulmonary hypertension. It was just something that I was interested to see if anyone sort of linked the two. So yeah, you can easily make the argument that this was all arrhythmia. How would you approach this case? So this is a young man with syncope. So the differential list, although it's the same as the 65-year-old, there's a different list, isn't there, really? Okay, because it's a hypertrophic cardiomyopathy comes up the list a bit more than postural hypertension. Okay, so there's you know that you can start making judgments on things. Now some are rightly and some are wrongly. Freya, there's one question that you asked, which you said any drugs. And I actually answered, I'm not sure if you noticed this, I actually said, no,
Yes.
I do not take any
Yes.
medications.
Yes.
And I think you could have clarified any recreational drugs. But I just wanted to see if
Okay.
you did that. That was just for future learning. So I think I've answered the heart failure cause that. Is that level case? I've answered that. Are there any good written collection of cases that you would recommend? So the Cases for Paces book has just been updated, I think. That's it's written by Hoole, Hoole. I may mispronounce that. And there is also the MRCP cases. Now, as I said right at the start of this, Adam, the collection of cases were written for the previous format of this exam. So the resources have been generated for the new ones, but it's not yet there. So those would be the ones I would go to as practice. And also the MRCP website has a few cases which if I were people on the webinar, I would save with a friend closer to the time. Any other questions? I hope I've answered all the questions. Okay, sorry, I missed this one. Any format tip for case presentation, please? So case presentation, 2 or 3 lines of summary. So in this one, it will be a 24-year-old gentleman that's presented after a syncopal episode whilst driving, associated with palpitations and loss of output. On clinical history and examination, he had signs and features that were consistent with thyroid excess that included smooth goiter, fine tremor, and brisk reflexes. My next investigations are electrocardiogram for hematobiochemistry, and also in particular, a thyroid function test with thyroid receptor antibodies, looking for a diagnosis of Graves' disease. Sorry, I was distracted. What is the MRCP cases book? There's Cases for Paces book. Sadly, that if you just type in Cases for Paces, you'll find it. The author's called Holle. I'll put that in the chat in a second. Any other questions at all? As you can see, that's my summary. Remember, you can always preempt lots of questions that come up. You can always prepare for your stations in those minutes. So you can always think about what would come up. And it's trying to assess you being a medical registrar. So that's the key here. When will he be able to drive? So what do we think about that? At the moment, we don't know what his arrhythmia is. Okay, so we don't know whether he's got an arrhythmia. So the answer is determined on his investigation. So at the moment, you can't answer that question. Okay, so I think if he asks you that question, you will say if it's like let's say it's AF or an arrhythmia, then yes, 1 month. But if it's not that, and if it's something else, then it will be until it's safe, okay, to drive, and until you determine the diagnosis, because you can't offer an answer until you have an understanding of the course of his diagnosis. Any other questions at all about PACES in general? I have no shares in Cases for Paces. It's a book that I used in the past, and I thought it was quite a small, nice book to read. But there are lots of books with lots of scenarios. So just see what sort of works for you. But they are quite old now, most of them, and they're not updated the new, as I said, the new format. But hopefully they'll start being updated. Any other questions at all? Perfect. Well, I'll hang around for 2 more minutes. Please do. I'll ask Shay before we do the buddy system for this diet. Yeah, so I'll pass that message on to him. Last time we actually set up some WhatsApp groups, so smaller groups with a few members of of the WhatsApp group, sort of, and with one member of the faculty, to sort of ask questions about PACES in general. So I'll ask if that's something that we could facilitate this time. So I'll ask him.